All right, this is going to be Chapter 13, the Cardiovascular System, Blood Vessels and Circulation, Part 2. And autoregulation of blood flow, we're going to talk about some terms here, and vasodilators, and these would be exhibiting factors that would promote the dilation of the precapillary sphincter. And we have vasoconstrictors, which these would promote factors that would stimulate the constriction of the precapillary sphincter. One of the things that constricts the vessels is going to be oxygen. Oxygen causes vasoconstriction, and oppositely, carbon dioxide causes vasodilation. We have nitric oxide. Anytime nitric oxide is produced, it's going to cause dilation of the vessels. This is one of the pathways that we actually work with whenever we give things like nitrates. Formation and production of nitric oxide. Neural control of blood pressure. We have cardiac centers and vasomotor centers in the medulla oblongata. They control the cardio-acceleration and cardio-inhibitor centers, which pretty means the heart's gas and the heart's brakes. Venoconstriction, which are vasomotor centers also located in the medulla. They cause vasoconstriction and vasodilation, and the vasomotor centers in general. These are just terms. Vasomotor centers, they will cause both of these, either constriction or dilation. And vasoconstriction of the arterioles and the peripheral veins is what we get off of this. So if we send off vasoconstriction, the arterioles constrict and the peripheral veins constrict. This gives us a little bit more blood supply. Vasomotor centers are located in the medulla oblongata, and they regulate blood pressure and other homeostatic processes. We also have two other centers, cardioacceleratory center, which increases cardiac output through sympathetic stimulus, and this is going to be through the use of epinephrine and norepinephrine. And then we have cardiac inhibitory or cardioinhibitory centers, which reduce cardiac output through parasympathetic stimulus, and this is going to be the 10th cranial nerve, or the vagus nerve, which innervates the heart on the parasympathetic side. This is kind of how the whole regulation system works, and we're going to kind of talk through this. So let's start here. We have normal blood pressure and volume, and let's say that homeostasis is disturbed. Physical stress, and this can be caused from trauma, high temperature, chemical changes, decrease in the amount of oxygen, or pH, which would be, as the pH decreases, this would make them more acidic. An increased CO2 or prostaglandins, or increased tissue activity. So running, jumping, running from T-Rex, all of these might be initiate disturbance of homeostasis. This makes inadequate blood pressure and blood flow, and then the autoregulation things kick in. Let's talk about the upper pathway first here. So both of these occur. Neural mechanisms, stimulation of the receptor sensitive to change in the systemic blood pressure, and these activate the cardiac acceleratory centers, so let's speed things up, and we get a short-term elevation of blood pressure by sympathetic stimulus, and this is going to be through the use of epinephrine and norepinephrine and peripheral vasoconstriction, and hopefully this will maintain or restore homeostasis. If that does not work, then we get more of a long-term effect, and this pathway down here is more long-term. So the kidneys get involved in this. We have the adrenaline gland here, and then in the kidney proper we have hormones that are secreted by it. Stimulation of the endocrine response in the kidney area, and we get a long-term increase in blood pressure and blood volume, and this is going to be through things that we talk about later. ADH will be stimulated in this, renin, aldosterone. All of these will have a specific job or specific function, EPO, and be secreted or brought into play by the kidneys into the systemic circulation. We have baroreceptors, and this is more terms. Baroreceptors, we have them in the aortic sinuses, and these pretty much look at pressure. Involved in cardiovascular regulation. We have them also in the carotid sinuses, and they're in the carotid arteries. Baroreceptor reflexes, autonomic reflexes that adjust cardiac output. They pretty much increase blood pressure. Baroreceptors in the carotids respond to provide stimulus. The cardiac inhibitory centers and cardiac vasomotor centers does two things. One, it causes vasoconstriction, and the other thing it does is increase the heart rate. So the vagus nerve releases ACH, which reduces the rate, and that would be the inhibition side. Inhibition of the vasomotor center leads to dilation of peripheral vessels and arterioles throughout the body. Those are one of the things it does. The other two things that it does is up here, whenever it's increasing blood pressure, which would give a sympathetic response, we would inhibit the cardiac inhibitory centers and excite the cardiac, let me pull back to that page, and excite essentially the cardiac going the wrong way. Cardiac acceleratory. I could not think of this. My apologies. So whenever we're doing the two things, what it's going to do is it's going to shut this system down where there's no brakes on things. And this is to increase cardiac output and increase the cardiac acceleratory center, which will give us a sympathetic stimulus. And very simply, whenever we're looking at this, this kind of works like this. So whenever we need an increase in blood pressure, we get a decrease in the amount of parasympathetic stimulus and an increased amount of the sympathetic stimulus. This is going to make the heart beat harder, faster, stronger, and give us a vasoconstriction and increased blood pressure, hopefully. On the same side of it, the inhibitory part of the heart, we kind of tell it to take 5 because until the blood pressure gets at the adequate level, we're not really going to need it. Chemoreceptors, which this is chemical, responds to changes in carbon dioxide, oxygen, pH of the blood, and the CSF. We have these in the carotid bodies and the aortic bodies. Both monitor chemical composition of the arterial blood. This is also triggered from the medulla oblongata, which monitors composition of the CSF. So we're looking for pH, CO2, O2 in the CSF. We primarily run off of CO2 in the body, the respiratory drive, unless we're on a hypoxic drive system. Homeostasis, or everything within normal range. And then let's start on this side. Blood pressure rises above normal range. The reflex and the baroreceptors say, wait a second, we need to kind of slow things down. Vasomotor sisters, the easiest way is going to be the first one. Vasomotor centers are inhibited, which is going to cause vasodilation. The cardiac inhibitory centers are stimulated. Or in this case, whenever we're talking about the blue, my apologies, this isn't in this. This is the actual pathway. Cardiac acceleratory centers are inhibited. This would be for a rise in blood pressure. We want to slow things down, so we do not allow them to press on the gas, and we essentially slow down the cardiac output, which decreases the cardiac output, and between the two of these, we get a decreased blood pressure. On this side of it, homeostasis is disturbed. Blood pressure falls below the normal range. Now in this case here, we're going to need an increase in everything. Reflex response, baroreceptors are inhibited. Vasomotor centers are stimulated, so this causes a vasoconstriction. Cardiac centers are inhibited. Cardiac inhibitory centers are inhibited, so the brakes, there's no brakes. And then the cardiac acceleratory centers are stimulated, so we just got gas order, which hopefully increases the cardiac output. And between these two, hopefully we get an increased blood pressure and homeostasis is restored. This is figure 1311 in your book. This is off of the chemoreceptors, looking at pH, O2, CO2 levels in the blood and CSF. So homeostasis is disturbed, you're becoming more acidic, your O2 levels are dropping, and your CO2 levels are rising, all in the blood and CSF, and this stimulates those chemoreceptors, which cardiac acceleratory centers are stimulated, more cardiac output. Cardiac inhibitory centers are inhibited. Let's take the brakes off for a second. Vasomotor centers are stimulated, causes a vasoconstriction. Hopefully we get an increase in blood pressure, and the increased pH, CO2 levels decrease the oxygen, the CO2 content in the blood. So all of this is moving things at a faster rate now. In response to that also, we also got a respiratory center that was stimulated off of this, which increases more of the supply. Hopefully this will restore homeostasis. Hormones that regulate the cardiovascular system. Endocrine system provides short-term and long-term regulation of the cardiovascular performance. In the short-term setting, we use the two primary adrenergic hormones, epinephrine and norepinephrine, and they pretty much stimulate cardiac output and give us vascular control. They increase peripheral vascular resistance. The next thing that we use quite readily is going to be ADH, or antidiuretic hormone, and this is going to stop diuresis. It does this with some additional help. Renin is going to be released at some point in this, and this would be from the kidneys. Renin is going to assist with renin, angiotensin 1, angiotensin 2, and ACE in the middle here. So when renin is released, it does several things. It helps fortify the ADH signal. It also releases angiotensinogen, which will convert to angiotensin 1. ACE then converts it, angiotensin converting enzyme, and angiotensin 2, and this causes arterial constriction. So the angiotensin 2 here is actually caused from a cascade of the kidneys. Also, the kidneys being involved in this, they will release EPO hormone, and EPO is erythropoietin hormone, and it's going to stimulate red blood cell production in the actual bone marrow and mature them at a faster rate. The negative feedback system on this is going to be atrial natriuretic peptide, which, when atrial natriuretic peptide is released, reduces blood volume and blood pressure by increasing loss of sodium. So the aldosterone released from the kidneys and the angiotensin and the ADH all pulled sodium in, and water followed it, so blood pressure increased. The atrial natriuretic peptide is actually the negative feedback, or the brakes on this, which is going to stop that process, get rid of more sodium, promote water loss, increasing urine, reducing thirst, blocking the release of ADH, which releases aldosterone, epinephrine and norepinephrine, and stimulating peripheral vasodilation. So the ANP does just the opposite of all the rest of the stuff that we just talked about. Figure 1312, normal blood pressure and blood volume, and in this case we're going to say that homeostasis was disturbed, decreased blood volume and blood pressure. In the short term, we're going to release epinephrine and norepinephrine, and hopefully this is going to increase blood pressure. In the long term, renin leads to angiotensin 2 activation. From that, we get antidiuretic hormone from the posterior pituitary, aldosterone is secreted from the adrenaline gland, thirst is stimulated. All of this increases blood volume. We also, from the kidney, get EPO, erythropoietin hormone, which makes more red blood cells, which will carry more supply, increase in blood pressure, increase in carrying capability, and hopefully through all of that, homeostasis is restored. The things to remember here is, in the short term, we have sympathetic adrenaline that is utilized. In the long term, we're going to need the kidneys for a very long-term adjustment of our blood pressure. And this one here, this would be the negative feedback system on this. Normal blood pressure, pressure volume. If we got an increase in blood pressure, atrial natriuretic peptide is released by the heart, which increases sodium losses, increases water losses because water is going to follow sodium, reduces thirst, blocks ADH, aldosterone, epi and norepi release, and provides peripheral vasodilation. This is going to reduce the blood volume and reduce the blood pressure. Hopefully homeostasis will be restored. Patterns of cardiovascular collapse. Exercise and the cardiovascular system. The cardiovascular system's response to hemorrhage and shock. Cardiovascular system operates in an integrated way that maintains homeostasis in response to two common stresses. And one of those stresses are going to be exercise, and the other one is going to be blood loss or hemorrhagic shock. Exercise in the cardiovascular system. During exercise, cardiac output and the pattern of blood distribution change markedly. Extensive vasodilation due to the rate of oxygen consumption is occurring in the muscles. Venous return increases, skeletal muscle contraction increases, cardiac output rises, which increases Frank-Starling's law, which is if you stretch something to a certain point or greater output, or stretch something to a certain point, you'll get a greater output. Short-term BP elevation is done through sympathetic hormones, epinephrine and norepinephrine. Long-term is going to be ADH, aldosterone, EPO, renin from the kidneys. So the cardiovascular response to hemorrhage, short-term elevation in blood P, almost immediate response within the carotid and aortic reflexes increases cardiac output, and this is through the utilization of epinephrine and norepinephrine at the target organs. Long-term restoration of blood pressure requires antidiuretic hormone and aldosterone. Aldosterone increases sodium reabsorption, which will promote fluid retention and reabsorption of sodium into the kidneys. Erythropoietin targets the bone marrow and increases blood volume and improves oxygen delivery in the actual tissues. Shock is essentially hypoperfusion, and in hypoperfusion we have various states. So you have three problems in shock. It is either a pump, container, or fluid problem. So whenever we talk about cardiogenic shock is a pump problem. Hypovolemic shock is a fluid problem. All of these are a container problem. So neurogenic, anaphylactic, and septic essentially occur from the vessels themselves being too large. In neurogenic shock, we have a sever of the spinal cord. There's no more stimulus coming to those vessels, and the vessels kind of lose their ability to constrict. So they open up and dilate, and this causes vasodilation and the loss of blood pressure. In anaphylaxis, we have a histamine release that occurs in the body, and this causes widespread massive vasodilation. In septicemia, we have exotoxins and endotoxins by the dead bacteria that have initiated a cellular mediated response with the immune system. In septicemia, between our toxins that our white blood cells are releasing and the exotoxins that are occurring from the death of the bacteria, this breaks down the vascular walls. Once this occurs, we've lost the ability to constrict our vessels, and blood pressure essentially goes down or becomes hypotensive from there. The blood vessels, pulmonary circulation, acute pulmonary embolus, the systemic circulation, aneurysms, vasculitis, acute arterial occlusions, peripheral vascular conditions, and fetal circulation. The pulmonary circuit and the systemic circuit. Essentially, we have a vascular circuit or a vesseled circuit not only in the lungs but also to the system. The pulmonary circuit is composed of arteries and veins that transport blood between the heart and the lungs. The systemic circuit is composed of artery and veins and transport oxygen, blood, nutrients, and deoxygenated blood back to the heart. This is a listing of the pulmonary and systemic circuit. So starting from the right atrium, this is the heart right here. It goes into the lungs, it's oxygenated, it comes out, it goes into the left atrium. That is considered the pulmonary circuit. The left atrium then pumps it to the body. This is considered the systemic circuit. And then it comes back to the right atrium again. Pulmonary circuit would be the oxygenation in the lungs. Systemic circuit would be the oxygenation of the distal tissues. Pulmonary trunk, circulation through the lungs, that carbon dioxide is released and blood is reoxygenated. Left and right pulmonary arteries are two large arteries that enter the lungs before branching out into multiple smaller vessels. And we have pulmonary veins, which return oxygenated blood to the left atrium. This is a more accurate picture of the pulmonary trunk circulation. Again, right atrium, blood traveling through, oxygenation occurs, comes back in on the pulmonary veins, goes out to the systemic circuit, capillaries, comes back in on the venous side, and gets oxygenated all over again. Whenever it's in the actual pulmonary circuit, these things here, these capillary alveolar membranes, and this is a capillary, they're only about 1 red blood cell in width. And what these allow is for easy diffusion and the movement of oxygen and CO2 through that membrane. Clinical notes: acute pulmonary embolism. An acute pulmonary embolism, particle lodges in the pulmonary artery or smaller branches, may be complete or partial, caused by prolonged immobilization and stagnation of the blood. If you have a clot that travels into the right atrium and lodges in the pulmonary artery, no more blood gets circulated through the pulmonary trunk. This would be devastating, and this is what a pulmonary embolus is. They can be either partial or complete. Right heart failure versus left heart failure. Now, we always spill fluid or have stagnant fluid in the previous container whenever we're in heart failure. So we essentially have two hearts. We have one that pumps blood into the pulmonary trunk, and we have one heart that pumps blood out to the body. Left heart being one of these and right heart being the other. It is always going to be stagnant in the previous container. So the previous container to the right heart is going to be the periphery. Previous container to the left heart is going to be the lungs. This person here has pedal edema, ascites in his belly, an engorged liver and spleen. All of this is caused from right heart failure. Systemic circulation begins with the left ventricle and ends with the right atrium. Left ventricle, it's ejected out into the blood, aorta, arteries, arterials, capillaries, venules, veins, and coming back in on the right atrium. And then from there, it gets pumped into the pulmonary trunk. Systemic arteries are the aorta, arch in the descending. Subclavian arteries branches to the arms and arterial blood supply. Carotid arteries supply blood to the brain. The descending aorta supplies blood to the lower extremities. And these are quite a few pictures in this, if you will just become familiar where the carotids are versus the aorta, subclavian, abdominal aorta, femoral, popliteal, dorsal pedis, radian ulnar. Just kind of overlook and be sure you're aware of all of those arterial spots. Some of them we actually check pulses on. The subclavian vein or the subclavian artery would supply blood to essentially the entire arm. And this is a breakdown. Like I said, this is going to be a familiarization of the anatomy. Please be familiar with how the actual blood is flowed through the body. Carotid, they're still on the arterial side. Middle cerebral artery. Aorta, abdominal aorta. Superior and inferior vena cava, and this is going to be on the venous side. Venous return from the head, trunk, venous return from the upper limbs and chest, and the inferior vena cava not only has the blood supply return from the lower part of the body, it also has the blood supply return from what's called the hepatic portal system. And these are all the veins. Again, look over those. AC antecubital, vena cava, subclavian, jugular veins, movement of blood into the superior vena cava. Portal circulation system. If everyone will take a note to this and take a long look at this, this is going to be figure 1328, that all of the organs in the, essentially the abdomen, are run through the liver before actually going into the inferior vena cava. This is why if you have an alcoholic that has a fatty swollen liver or has hepatitis, that they may have something called ascites, which is fluid in the abdominal or peritoneal cavity. This is caused from a backup or clogging of the venous structures due to a fatty liver or a cirrhotic liver. Clinical notes on aneurysm. Aneurysms can be caused by atherosclerosis, and atherosclerosis are fatty deposits and high pressures, or atherosclerotic would be caused from fatty deposits and high pressures. Dissecting degenerative changes in the connective tissue. The number one infectious process that gets us an aneurysm is going to be syphilis. Congenital, we might see things like Marfan syndrome. This is what Abraham Lincoln probably had, where your arms are longer than you are tall. Traumatic transection of the aorta may occur from cavitation waves and or gunshots that occur due to displacement in the abdominal and or thoracic cavity. And a AAA is may give us signs and symptoms of acute ABD pain, back pain, flank pain, hypotension, and the big thing here to watch for, the patient has the urge to defecate. This is also going to happen if they have retroperitoneal bleeding or bleeding by the kidneys. Vasculitis, which is essentially inflammation of the vessels, and we have something called Raynaud's phenomenon, the episodic ischemia of the fingers and toes, cyanosis, and it's pretty much going to give the patient pain. This would be a normal temperate room that the patient's hands all of a sudden turn blue and felt cold from. It's caused from a vasospasm of the actual arterial side and makes hypoxic areas. These hypoxic areas will actually cause pain and ischemia pain. Acute arterial occlusion, decreased or absent blood supply. This is going to be on the arterial side. And the easiest way to get rid of this is going to be through surgical removal or angioplasty. That's where they put a big IV in there and they go in there and they either screen it and catch it or they dissolve it. Peripheral vascular conditions are going to be peripheral arterial atherosclerosis, deep vein thrombosis, which will give us a positive Homan sign, and then varicose vein. A positive Homan sign is seen whenever a person has a deep vein thrombosis and it's occluding return flow in there. This causes ischemia to the actual muscles in the calves. A positive Homan sign would indicate that upon pulling the toes upward and stretching the calf, that you would actually have more pain in the calf area. So if you have somebody that has an isolated swollen extremity distal and you pull their toes up and they have an increasing in pain, this would be considered a positive Homan sign. Fetal circulation, we're going to talk about placental blood supply, circulation of the heart and great vessels, and circulation changes at birth. And I'd like to point out this, there is no vascular hardwire between mom and kiddo. It is all actually facilitated through the placenta. This is the child's organ. The lungs are deflated and they don't actually inflate until they take their first breath. This allows the heart actually to be kind of piped backwards at this point. They have an atrium that has an opening to where they have collateral circulation, and they have a ventricle that has the same thing. They also have ductus arteriosus that goes between the aorta and the pulmonary veins. So what this allows the heart to do is to allow for collateral circulation of oxygen that is achieved or gotten by mother and then transmitted to the placenta during her normal circulation. After they're born and they're delivered, due to the inflation of the lungs the first time, these holes close, and this, now under a different set of pressures, actually stops becoming patent. This may take up to 3 to 4 days after the child is actually born to completely close up all the way. Aging in the cardiovascular system, vascular trauma or aortic rupture can occur. Deep fissures, the cuts that are essentially running sideways to the actual arterial supply, seem to do the best. The smooth muscle in the vessels will close up and cause constriction and contraction to occur. This decreases the amount of blood flowing through them. The ones that are kind of hard to stop are the longitudinal, which are on the long axis. These things, as the backside constricts, will actually open up the wound site more. This is figure 1331. This is of aneurysms. And within an aneurysm, what happens is, and we're just going to talk about a type C1, please look over these. The connective tissue on the outside tunica eventium kind of bulges. And then you have sections from the tunica media to the tunica intima. And what can occur is the tearing sensation is generally felt from this area bursting. And now blood is filled into the entire false lumen. Now what generally occurs from that is this gets larger and larger until finally it becomes underneath enough stress to where it bursts. But the tearing sensation is generally felt whenever they have a tearing of their tunica intima and tunica media into the false lumen. Aging in the cardiovascular system. The body, as it becomes older, doesn't work as well. We get a decreased hematocrit or decreased amount of red blood cells, constriction or blockage of peripheral veins and thrombus formation, pooling in the legs because the valves don't work as effectively as they once should. The heart, reduction in the maximum cardiac output, changes in activities of nodal and conductal cells, reduction of elasticity, progression of atherosclerosis, replacement of damaged cardiac cells by scar tissue. All of these things are going to decrease the pump's efficiency. The replacement of damaged cells in the cardiac and by scar tissue is essentially facilitated. The scar tissue doesn't contract as the myocardium once did, so this is going to reduce the amount of ejection that is occurring from the ventricles during contraction. The vessels themselves, they become inelastic and become hypertensive. Calcium deposits pretty much weaken the walls, and this is from the formation of atherosclerosis. Thrombi can form and atherosclerotic plaques can develop. Please look over the integration with other systems. The cardiovascular system essentially pipes hormonal information, nutrients, oxygenation to all systems. As far as terms to know, an anastomosis is a new pipe built by the vasculature. Arterial is a small artery just before the capillary. Artery is the muscular area just before the arterial. Blood pressure is going to be a combination of systolic and diastolic. Capillaries are going to be arteries, arterioles, capillaries, venules, veins, the smallest lumened vessel in the body. Hepatic portal system will allow for the filtering of all the blood returning into the liver. Peripheral resistance is the amount of pressure or resistance on the actual vasculature system. Pulmonary circuit would be where the blood got oxygenated. Pulse pressure is the difference between the systolic and the diastolic. Example, 140 over 120 would equal a pulse pressure of 20. Respiratory pump, whenever the actual lungs deflate, this is what assists the central venous side to put blood into the right atrium. And then we have systemic circuit, which is the circuit that takes the oxygenated blood to all sections of the body. A valve, which is more, we're talking about the valves in the veins, which stops backflow or pooling. Vasodilatory, which means vasodilation. I got these out of order. Vasoconstriction, which means the actual vessels themselves become smaller. And this one here, vasodilatory, the vessels become larger. A vein, return side of deoxygenated blood in the systemic circuit. And a venule would be on the other side of the capillary. Artery, arterials, capillary, venule, vein. The venule would be right here. And that concludes part 2. If you have any question, feel free to contact me. Name's Roy Smith, 405-219-7613, or you can shoot me an email at smith@msa.net. Thank you.